The next is going to be a most important session, which is the plenary session. I humbly request Dr. Amir Hamrahian to talk about evaluation and management of adrenal insufficiency in critically ill patient. To chair the topic, I request Dr. B. Bhaktavatsalam, Senior Physician, Sim Salem Hospitals, Salem, to come to the dais. Also, Dr. S.K. Singh to talk about epidemiology of diabetic foot infections in India and rational antibiotic use. And to chair the topic, I request Dr. E. Thangavelu, Senior Physician and Podiatrist from Monica Hospital, E Road, to humbly join the dais.
I am very glad to introduce Dr. Amir H. Hamrahian. He is currently the Chief of Endocrinology Department in the Medical Subspecialties Institute at Cleveland Clinic, Abu Dhabi. He joined Cleveland Clinic in 2000 and Cleveland Clinic, Abu Dhabi as seconded physician in 2014. He specializes in endocrinology and has a special interest in pituitary and Amir has published more than 80 peer-reviewed articles. He has served as co-author in developing guidelines for pituitary and adrenal disorders. He has given presentations on pituitary and adrenal disorders at national and international conferences and has served as principal investigator for a number of clinical research studies. He is a professor of medicine at Cleveland Clinic College of Medicine of Case Western Reserve University. He has recently accepted an offer to join the very famous Johns Hopkins University to develop their adrenal program. He is going to talk on evaluation and management of adrenal insufficiency in critically ill patients. And I think this is a very interesting topic because in septic shock, and this is a big problem, whether to use steroids, because many a times in shock patients, there is a real problem after volume augmentations and after vasopressors, the patients do not respond. Whether to use steroids and how we are going to really document whether the patient has got any steroid insufficiency, because there is a problem. Whether there is a real adrenal insufficiency, how to document. I think here is a master who has done a lot of research, and we have to hear from the masters. He is the master who is going to guideline. Thank you, sir. Over to the speaker.
Okay, almost good afternoon. It's an honor to be here. Thanks to the organizing committee for the invitation. It's a first trip to India, and thank you for your hospitality. Had a great time so far. So during this relatively short talk, I'm going to take you to some new data in the last couple of years about the cortisol production and clearance in the critical ill patient. There are some new insight to the pathophysiology in this disease. We'll review some of the limitations associated with the measure of the total cortisol that you may be aware of that. And then the concept of free cortisol, to explain some of the pitfalls with the commonly used this concept of the relative adrenal insufficiency, which actually we hear less about it. And that's a good thing with this concept, with this, in my opinion, not well defined concept. And then about the glucocorticoid dosing in the ICU patients. And then I'll give you an algorithm that when I get called to see a patient in ICU for adrenal insufficiency, what I follow as an algorithm. We are not the frontline doctors for taking care of this patient, but we get called at times to see this patient. So we need to have a strategy how to manage this patient. Just a little review about the HPA axis activation in critical ill patient. And you have the CRH, hypothalamus, ACTH, and then you have cortisol production, adrenal glands. AVP can stimulate the ACTH secretion in the presence of the CRH. And then you have a number of the factors, including autonomic nervous system and a number of other factors, cytokines, a number of the peptides, can affect the axis at different levels. It seems that the majority of effect is at the adrenal gland, but they can affect it at any of these hypothalamic pituitary levels as well. And then you have in the critical ill patient decreased binding proteins because of the liver disease malnutrition, which also releases kind of a cause elevation of the free cortisol. Then you have the neutrophil elastase that can cleavage the CBG and cause increased free cortisol availability at the site of the inflammation. And beyond this, there is also the whole concept of the glucocorticoid resistance, whether there is any changes in the receptor expression and signaling during the critical illness. What is new now is our understanding of decreased cortisol clearance in these patients. We know that these patients have decreased clearance in the kidney by decreased expression of the 11-beta HSD type 2 that converts the cortisol to cortisone, and also in the liver. So there are two major sites that there has been shown that there is a decreased cortisol clearance in these patients. And bile acid has been one of the things that has been thought as be a culprit in these patients contributing to this decreased clearance. I'm going to go over that because I think it's important to spend a little time on that. We know in the ICU patient that increased cortisol levels are associated with increased mortality. This has been shown along the years. This is an old study. I like them as long as they kind of convey the same message. You have the control normal subject, you have the survivors and fatalities with septic shock. As you can see, their cortisol levels in these patients are much higher than the normal subjects. In the survivors, only 1 out of the 8 patients had a level more than 60 microgram per deciliter. When you come to the fatalities, 60% of them had a level more than 60 microgram per deciliter. And when you get to a level of about 70 to 80 microgram per deciliter, almost the fatalities become 100% in ICU patient. Now, contrast to this, we have not been able to come up with the threshold under which there is a significant mortality in ICU patient. We know that the high levels are associated with high mortality, but we are struggling with finding it in the level in the low side that cause increased mortality. We know in ICU patient that in the first couple of days, sometime in the first 24, 48 hours, or maybe in this study after 3 days, while you have the septic patients here with multiple trauma and you have a controlled subjects, you have the cortisol and ACTH. While the ACTH and cortisol initially are kind of both high in this population, after a couple of days you see a dissociation between these two. So the patient continues to have elevated cortisol, but their ACTH level actually goes lower than the control subjects. We have thought before that this may be related to some non-ACTH kind of a dependent pathways that causing that. Cytokines have been kind of thought to be postulated to be the main culprit here. But now we have some information that decreased cortisol clearance that may be the reason for this dissociation in addition to other factors. So in the University of Leuven, Dr. Vandenberg group, that you all know about it, of the insulin infusion, the ICU, they look at the 160 patients in the ICU and about 60 control subjects in the same area, sex and age matched. When they look at and they give this patient deuterated cortisol and cortisone, and then they look at their labeled one and their metabolites to find about the cortisol production and clearance in the ICU patient. What was interesting is that they found that the level of the cortisol secretion was less than twice the normal the level that is made by the controlled subjects. When they divided the patient to the one with the systemic inflammatory response syndrome and the one without it, these are all sick ICU patient, intubated ICU patient, but these are the one with the end organ failure or end organ damage. They found that the cortisol production in the ones without the systemic inflammatory response, without the septic shock, was almost the same as the control subjects. There is no significant activation of the HPA axis in this patient. Only these other patients are the ones that they are mild to moderately elevated cortisol production. When they look at the cortisol clearance, they found that there was more than 50% decrease in the cortisol clearance in this population. And this was independent of whether they had significant inflammatory response or not. So in all these patients in the ICU, across the line, they have significant decrease in the cortisol clearance. When they give 100 milligram hydrocortisone to this patient and they look at their area under the curve and look at the half-life, there's a significant increase in the area under the curve in the critical ill patient. And the half-life of the cortisol increased by about 5 to 6 folds. This may be an adaptive process. I mean, we cannot store cortisol, so the body needs to make it continuously. So that may be a way to kind of conserve energy, if you think about it that way. So the overall 24-hour rates of cortisol production during critical illness might not be, or at the best, only moderately higher than production during the health. These patients have reduced cortisol clearance in all tested patients, irrespective of the type of the disease they have, severity of illness, duration of stay in ICU, and their prognosis. So decreased cortisol clearance at least seems to be based on these studies, which come from one university hospital setting, but this is very interesting. That is the main underlying cause for the elevated cortisol in this population. And this has been really a U-turn in our understanding of the adrenal insufficiency in critical ill patients. How prevalent is this problem in the ICU patient? This is a study from 2011 looking at the 2001 looking at the number of the studies that use ACE stimulation tests, and these numbers ranges from 0 to about 75%. I mean, so how can we have 70%, 60% adrenal insufficiency in critical ill patient? Is it possible? So, in my opinion, this is definitely exaggerated, overestimated, and there are a number of reasons for that. And the reasons I have kind of summarized some of them is that. One of them is that the issue of the binding protein, that the cortisol is not a very good tool to evaluate adrenal function when you have a low binding protein. You can have increased false diagnosis, positive diagnosis here. And then the introduction of the relative adrenal insufficiency has caused a significant increase in the prevalence of adrenal insufficiency. And I'm going to show you a couple of slides about that. And the other issue that I have sometimes kind of discussed with my ICU staff is that they feel that whenever they give a steroid to a patient and the blood pressure goes up, they think that the patient has adrenal insufficiency, which is not true. At the times in 1950s, 60s, when they used to do bilateral adrenalectomy, thinking that in patients with metastatic disease, there is improvement in survival. These patients, when they give them a steroid, they had significant improvement in their condition, blood pressure, within 12 hours. Even in the patient with pituitary disorders, we see improvement in the hemodynamic and the patient well-being after pituitary surgery when they have adrenal within 24 hours. However, when they did the randomized study, like the corticosteroid studies, the improvement in the blood pressure defined more than 90 millimeter mercury in these patients, whether they had response or no response to the ACTH stimulation, was about 3 to 4 days. So the timeline also doesn't fit adrenal insufficiency kind of a concept in this patient. And it may to do something with the effect of a steroid on the upregulation of the catecholamine receptors and the vasculature and decrease in the inflammation in these patients. So what are our tools to evaluate these patients? I mean, I have written the test that we can do in this patient to evaluate adrenal function. When it comes to the critical ill patient, we probably end up with the random cortisol, ACE stimulation test, or salivary cortisol. There are some data on salivary cortisol. It can be a little challenge to obtain saliva in some of these patients. Studies have been shown a failure rate of 5 to 25, 30%. So I would say at this point it's not a standard test to evaluate adrenal function in critical ill patient, but definitely it's a promising because you can measure free cortisol in saliva with a good correlation with the serum free cortisol. And it's a very much easier to do the test. So, as I mentioned, we have failed to come up with a threshold for diagnosing adrenal function in this patient. And there have been different criteria has been kind of proposed by experts, from 6 microgram per deciliter up to 34 microgram per deciliter for adrenal insufficiency, with some of them literature support, some of them expert opinion. So let's talk of just one or two slides about free cortisol. As you know, about 10% of the cortisol is free, about 80% bound to albumin, and about 10% to CBG. Albumin is a high capacity, low affinity, and CBG is a low capacity, high affinity binding protein. And we know that the free cortisol is the one that goes to the cell and binds to the receptors and responds for the post-receptor actions. So when you have a cortisol in normal patient, about 20 to 22 microgram per deciliter, your CBG start to get saturated, and then you start to have a significant increase in the albumin-bound and free cortisol. What happened in the critically ill patient, because they have a low CBG, the cortisol start to get saturated at much lower levels, and accordingly you have a much higher, my slide didn't, I don't know, maybe because of the program difference, but anyway, you have a much higher increase in free cortisol, and the more important part for the albumin bound to play a role in the cortisol concentration. We did a study in 2004, and we look at the total and free cortisol, and we showed that you look at, if we divided the patient to the patient with the albumin less than 2.4 and more than 2.4, this was the best cutoff to show us to differentiate between the two groups, the difference between the total and free cortisol. For example, if you look at the patient with the significant hypoalbuminemia, more than half of the patient had a cortisol less than 15, which many use as a cutoff for diagnosing this patient. But when we look at the free cortisol in the lower graph, the free cortisol in this group were identical and significantly higher than the healthy volunteers. So especially in patients with a low albumin level, as a kind of a surrogate of the binding protein, the cortisol can be low because of the low binding protein. Now, why don't we measure the free cortisol? I mean, what is the problem with that? So but the issue is that you need to mechanically separate the cortisol from the binding CBG, and that is not easy. The equilibrium dialysis and ultrafiltration are the way to use. These are labor intensive and cumbersome, so usually there is about 7 to 10 days turnaround time to measure the free cortisol. So the people have come up with some ways to calculate the free cortisol using the model of the testosterone, but unfortunately these calculations are not correct. And I see very, very unusual numbers that cannot be true because of these calculations. So at this point, we do not have a good way of calculating the free cortisol level. This is a study we did looking at the 1 microgram, 25 microgram, and 250 microgram ACE stimulation test. But I'm not going to talk about that. We just look at the ITT in this patient also, the patient with the pituitary and controls, and we saw that all the patients with the normal axis had a free cortisol more than 1.3 microgram per deciliter using mass spec for measurement. If you use immunoassay, the level will be higher. And all the patients with abnormal HPA axis had a level less than 1.1. So I use 1.3 as a pass criteria for free cortisol. Now, a few words about delta cortisol and this concept of the relative adrenal insufficiency. This group was one of the first that brought this issue, that there was increased mortality in patients with the delta cortisol less than 9. And this followed by a study by Dr. Anon from France that they published in JAMA, and then they showed that in patients with the low delta, these are the patients with a relative delta less than 9 and the patient with a delta more than 9, if you give them hydrocortisone and fluorocortisone, there is improved survival. And this really was a big change in the practice of ICUs over the many countries, continents. However, there are a number of the pitfalls associated with this concept. And I'm going to touch base on one of these in the next slide. But there is important the relation between the basal and the delta. If you have a higher basal cortisol, your delta is lower. If you do AC stimulation test in the morning or you do it in the afternoon, you get a higher delta in the afternoon because your basal is low. There is a poor reproducibility of this. You measure the do the test today and do tomorrow, and you see more than 50% discordance. There is an effect of the cortisol binding protein. The patient who have a lower binding protein, they have a lower delta. And then the atomic factor, which I'm going to show in the next one, which I think has been a big important issue. And the next follow-up studies like Corticus, high-pressure study, the randomized multi-center European study did not show any benefit from hydrocortisone in patients with a delta or without a delta. And of course, now our concept about decreased cortisol clearance, that really it's not the activation mostly of this HP axis, but this is the clearance issue in the ICU patient. One of the major criticisms to the ANON study has been the use of etomidate. As you know, anesthesiologists like this agent, and it decreases the conversion of the 11-deoxycortisol to cortisol. So 72 out of the 300 patients enrolled in this study, they received etomidate within 8 hours of the testing. And 68 out of these 72 patients received etomidate were in the so-called non-responders or having a low delta. Without any doubt, this agent has caused some adrenal insufficiency in some of these patients. No revised data by these investigators was published about after looking at the data after excluding these patients. So this has been a major, and when follow-up studies, they try to make sure that the patient do not receive any etomidate at the time of the testing of the adrenal axis. So there are good news in the ICU literature. These are some quotes that I have from different international groups. We suggest not using the ACE stimulation test or co-syndrome stimulation test to identify the subset of adults with septic shock who should receive hydrocortisone. In patients with septic shock resistant to vasopressor and fluid therapy, a trial of glucocorticoid may be started, regardless of the serum cortisol levels, since the benefit of the glucocorticoid may be beyond adrenal insufficiency. And I can't say it any better. I think these are very nice comments that comes from our intensive care colleagues. It was interesting to see, for example, in this paper that they say the 10 diseases that are not true diseases. It's a ICU publication, and number 5 in that list was the relative adrenal insufficiency. So there is a kind of also agreement among our ICU physicians that are getting away from this concept of looking at the delta cortisol. Now, we need to mention about a few words about the assays, and that makes a difference. Again, sometimes becomes a playing with the numbers. When they look at the HPLC as a gold standard, and they look at the 3 commercially available assay, they found that more than half of these patients, there was no consistency in the diagnosis. When you look at the number, patient number 6, you can have an absolute adrenal insufficiency, relative adrenal insufficiency, or normal based on what assay you have done that. So that also makes the things complex. Probably mass spec is the way to go to avoid any problem with the other steroids that we may be measuring with the immunoassays. Now, this concept of the adrenal insufficiency in the ICU cannot be discussed without also thinking about the glucose resistance. Because always the question comes up, can this patient have resistance at different levels? And this can be at the level of the binding of the free cortisol to the glucose receptors, their translocation to the nucleus, their transactivation or transrepression of the downstream genes. So that concept, unfortunately, we don't have a good response for that. We don't have a good tool, clinical tool, to measure is there any significant resistance happening or not. We know that, for example, in this patient, when there's inflammation, you can have more expression of the glucose receptor beta type, which has a opposing action to the glucose receptor alpha type. You have decreased, as we talk about the cortisol clearance, you have increased free cortisol availability. So these changes may be associated with other changes that are happening at the same time that may be compensating for them. So my impression is that if a patient has a normal HPA axis, they should be able to overcome any resistance, and there should not be any problem in them. But we need more tools to look at this concept. Just a word about the dose of the glucocorticoid treatment in the ICU patient. Again, the same investigators showed that this is patient without, again, these are intubated sick ICU patients without the systemic inflammatory response, or patient with a severe septic shock. And as you can see, even in these sickest patients, the cortisol production is only about 60 milligram per day. So using doses of 200 milligram, 300 milligram hydrocortisone per day in ICU does not look like have any good evidence for that. And we may be hurting the patient with the poor wound healing, hyperglycemia, and that is something to think about that. At least once the patient is stable from a blood pressure, we should have a attempt to decrease the dose to about 15 milligram every 6 hours. That will be about 60 milligram a day until the patient in the ICU, and then we'll move out. And using higher doses really may not make sense, or at least not having a support for that. So when I see a patient in the ICU, my first question is if the patient is hemodynamically unstable or not. I mean, these are the patients I get called for. Many of these we don't get called for as endocrinologists. If a patient is septic shock, from my standpoint, no matter what the cortisol level is the patient is not responsive to the fluid and pressors, this patient may benefit from hydrocortisone therapy. A trial, a couple of days, if the patient blood pressure doesn't get better, doesn't become pressure independent, then the medication can be stopped. I don't know, I even don't want to know about what the cortisol level is in this patient. If a patient is stable but not septic shock or severe sepsis, I get the cortisol level back in 1 hour in my institution, but if you have a long kind of a time to get it back, you may want to start a patient until you get the result back. So I measured the cortisol. I mean, free cortisol right now is not practical to order because you get the result back in 7 to 10 days. So if a patient has near normal albumin, that means albumin more than 2.5, I think 15 microgram per deciliter is a good way to go. And these are not just made up numbers. These are based on the conservative estimate based on the free cortisol and the percentage binding protein. However, if the patient has a low albumin level, a 15 is too high, and you're going to diagnose too many patients with adrenal insufficiency. So I use a lower cutoff of 10 microgram per deciliter in this population. And of course, if I have the available data, mass spec, free cortisol, I use 1.3 as a cutoff. Now, if I do not, the levels are borderline, I prefer to repeat the levels once or twice more in a couple of hours. Just coming toward the end of my talk, we want to measure the free cortisol accurately and rapidly if possible. That is the way to go. I mean, we have done it for free T4. I mean, remember that 15 years ago, free T4 was a luxury in the ICU. Now the free T4 is our workhorse. I talked to Quest Diagnostic, they say it can be done. You don't need to go through this cumbrance of mechanical removal, but you need to have the demand, you need to have the energy and money put to this assay. So when there is a demand, they will come with measure that, as we do it for free cortisol. We thyroid free T4. We don't do equilibrium dialysis for free T4 these days. And the tandem mass spec probably is the way to go for most of our hormone measurements. We need to look at some biomarkers of the glucose action about this concept of glucocorticoid resistance. That is something that we don't have an answer yet for that. Some people have come up with the flow cytometry as a promising way to measure the nuclear and cytoplasmic glucocorticoid receptor, and then look at the cortisol at the same time and try to make sense of this relationship and the adrenal function in this patient. And additional studies examining the pathophysiology of adrenal dysfunction. Most of the recent data I shared with you come from one university hospital. So we need to have the repeat of these studies to make sure that these concepts are correct. So in conclusion, I have 1 minute to go. Elevated cortisol levels in critical ill patient is only partially explained by an increase in cortisol production. Impaired cortical clearance is the main contributor, at least based on what we know for now, to hypercortisolemia, which could be explained by suppressed levels of A ring reductase in the liver and the 11 beta HSD2 in the kidney. Relative adrenal insufficiency has been defined by the cosentropin stimulation test, a test which is not the right tool for this task with multiple potential flaws. In critical ill patients with low cortisol binding proteins, total serum cortisol is a poor indicator of glucocorticoid activity and can be misleading. So you need to be aware of that and use a different threshold. Despite, and I should say that I should confess, after looking at these data, following these since my fellowship for the last 15, 16 years, I would say that very humbly I can say that despite a large body of literature, we still have a hard time to define adrenal function in critical ill patient. And I would like to, the last sentence, recent studies call for evaluation of lower doses of glucocorticoids in critical patients suspected to have adrenal insufficiency, and thank you for your attention.
Shall we have question and answers now? I think we had a wonderful guidelines how to manage a critically ill patient with adrenal insufficiency. I think I have not read such a clear statement because I had been going through several literature. I think professor has given very nice guideline. Your questions, please.
I have a question.
Yes,
that was
please.
a great talk. Thank you very much.
Oh, thank you.
Of late, we have been picking up a lot of adrenal insufficiency in a liver disease patient. So I work in a liver unit where we do a lot of liver transplant work. So it's been, they do have some, characterizing them with a clinical symptom of adrenal insufficiency is very difficult with their fluid status and clinical examinations. But even with albumin, most of them are hypoalbuminemic. Even if you go by the cortisol of 10, of what you showed, that's what we take, and we don't do an ACTH stim test. And many of them do very well with a small dose of hydrocortisone, which sort of reverses post-transplant. Once a transplant happens and once they come off of steroids, and it stays like that. They don't have any residual adrenal insufficiency after that. So do you also see an increasing trend of, apart from critically ill patients, specifically in the subsect of liver patients, end-stage liver disease and liver failure, do you come across a lot of adrenal insufficiency? And
Yes.
I just want to know your experience.
Sure. So this is not the population that I have studied in detail. I mean, my interact with them has been generally when they have been called for a patient with liver disease. So I am not aware of, I mean, the problem in this population, this is one of the population that you would be tend to overdiagnose them. And I'm glad you are considering the albumin because many people don't. I just read a paper from my own country that the people in cirrhotic patient, they were doing ACE stimulation, they look at the delta, and then they're saying, 50% adrenal insufficiency. So it is great that you consider these things, but I'm not aware of any specific level for these people as a separate level. If you have a chance to measure free cortisol, I don't know how you can do that, but in some of these patients, maybe the steroid benefit may be beyond the adrenal function too. So I mean, there is a lot of inflammation going on in these people. So it is hard to say, but as long as you understand the concept, as long as you use the minimum dose necessary for the shortest duration of time, I don't have a problem with that. But we have a difficulty to define adrenal function in this population as well.
Right. So the free cortisol didn't really work for us. And as you said, we never do the ACTH. We don't take the delta. We don't measure ACTH. We just go by the cortisol, look at the patient, clinical diagnosis, and put them on steroids. It really helps them have a meaningful few days before they get the transplant. And once the transplant is over, they do pretty well.
I'll look forward to your publication on this. That's great.
I wish I could. Thank you very much.
That's great.
Thanks.
Okay.
Thank you so much for the wonderful session, sir.